I'm going to talk about the Athena Breast Health Network for probably the next 30 to 40 minutes. What is it? Well, this is a program that initiated with the vision of Laura Esserman up at UCSF, who's a breast surgeon, to create and facilitate rapid integration of research into care. So we established a network with a large community referral base, but largely the 5 UC campuses with cancer centers, as well as probably a year and a half to 2 years ago with Sanford Health, that is in the Dakotas. Every time I put the slide, they say you misspelled Stanford, but it's actually Sanford Health, and they're in the Midwest, and there are 13 hospitals. They have the network basically in all of the Dakotas. And really there's over 100 providers and researchers across primary care, radiology, pathology, surgery, medical oncology, and radiation oncology. And the initial goal was to focus at the time of screening and to create a registry of women coming in and to try to do some more sophisticated risk stratification of the population of women that are getting screened. And that effort to date has yielded over 85,000 women who are part of the overall network. And UCLA has done particularly well in that we have 60,000 of those women in our particular UCLA specific registry. And that includes about 8,000 women from all of you that are Latina and have a different sort of health literacy and socioeconomic sort of backgrounds. So that's the network. And the mission is to try to transform the way healthcare is delivered, to create a continuous learning environment, and to accelerate how innovation affects care. Although the initial strategic initiatives of the network focused on all aspects of breast care, going from prevention to screening and diagnosis to treatment and survivorship, and there are projects happening in each and every one of those domains, the majority of the effort and the success of the network has been largely around identifying high-risk women and prevention and screening and diagnosis. So this is where a lot of efforts going in personalized risk assessment, where you could target prevention counseling, really trying to look at what we would call precision medicine in this population, as well as you'll see focusing more on risk-based screening, tailored frequency, how to reduce false positives, etc. So this is the idea: is you have these patients and participating sites. The target initially, when the first phase of the project went live, was to recruit about 150,000 women. We thought that that would yield maybe up to 40,000 biopsies over the time of the project, with maybe about 20,000 diagnoses and maybe about 10,000 cancers. And the data coming in for this population would include electronic patient questionnaires that capture personal history and family history of cancer, to do automated risk assessments using a Gale risk model, as well as looking at U.S. Preventive Task Force criteria for hereditary risk, to then also being able to identify women that need genetic counseling, genetic testing, and then ultimately, as these women are diagnosed with cancer, staging, and then capturing their treatment decisions and outcomes. And the knowledge out part would be to try to see how effective these personalized risk profiles are. Is there some benefit in terms of helping identify who should get a biopsy or not? And then in extending to the cancer population, trying to do a better job with personalized breast cancer treatment options, and then risk-based trials, of which I'll talk about one of. And then there's been some efforts to try to link it to breastcancertrials.org in terms of just connecting patients to available studies and trials. But this whole process, in the middle of it, is this whole research and quality improvement piece, where there's a lot of opportunity, I think, for biomarker discovery, validation, biospecimen repositories, comparative effectiveness research, strategies for personalized medicine, and evidence-based management. And I think the value here is that this is one of the few, or at least one of the few projects that I know that's looking at trying to do population-based risk stratification and personalized medicine on a large screening population as compared to trying to do it in narrower populations of diagnosed patients. And so trying to figure out what the value of additional information and data is different when you're looking at screening populations that don't have a diagnosis versus those that do. So the infrastructure goals to be able to accomplish a project like this are very data driven. So there needs to be a framework of data collection, analysis, feedback, and sharing, because it's integrated research and clinical care. And so trying to identify the best way of doing that at the point of care, which is also, I think, a growing area of efforts to try to figure out how to integrate these processes in the point of care was a challenge in this, as well as identifying clinical and organizational barriers, obstacles, and feedback for the actual routine components of reporting that need to be part of the medical record. Ultimately, one of the goals were to kind of lower these barriers, try to figure out what sort of patient engagement platform would work, how to use the patient-reported data efficiently, how not to ask people to continually provide the same data over and over again. So as we move into the electronic world, to be able to utilize previously entered data in an effective way. And so ideally, you'd have this data source where you have patient-reported data, may include, for example, their history, previous sorts of treatments or mammograms, et cetera, and provider-based data, that there would be a variety of services that you would be able to drive off of those collected data, including genetic counseling, peer support, or interventions like smoking cessation or psychological supportive services and psycho-oncology, and then to try to have some automated outcomes and tracking as part of this process so that you can build in a continuous learning process that would allow you to really merge research and care in a way that would accelerate the approach that we take towards these types of projects. And I'm going to walk you through the sort of components of what we're currently doing and what is part of a PCORI pragmatic trial that got funded around this project. So a woman comes in and is scheduled for a mammogram. And so as part of the routine care, they get a health questionnaire. This is considered standard of care at all of the sites. They can complete it at home or in clinic. They can use an iPad, a kiosk, a smart form. The data that they initially put in gets fed into risk calculators that run Gale and a variety of other models to try to identify people who might have elevated risk thresholds. And this creates a personalized risk profile that gets communicated to the patient themselves, as well as to the primary care provider who ordered the mammogram. And so part of the innovation around this is that as we get to more personalized care, patients are going to have to become more accustomed to managing their own risk as well as their primary care providers. And this is going to be more important as the population expands and there isn't enough time for doctors to manage every element of a patient's risk. Co-sharing kind of the personalization and precision component of risk management between the patient and the primary care provider is an important component, as well as being placed in a database that we can track this population. If they're elevated at risk based on this risk profile, then they get referred to a breast health specialist. It's kind of a navigator. In this case, the navigator is a genetic counselor that can do either telephone genetic counseling and or can schedule an appointment for them to come in using a variety of clinical decision support tools. A variety of things could happen. It could be that a variety of lifestyle factors that would not only benefit breast cancer reduction, but improve their cardiovascular risk and a variety of other comorbid conditions that they have can be counseled. They might have formal genetic counseling that might then yield to genetic testing or a variety of other clinical interventions like chemoprevention. So this kind of directs a population of patients who may come in and who may have a normal mammogram and go home thinking, okay, this year they don't have to worry about breast cancer, but who may otherwise be at very high risk and who don't know it, to be able to then be able to engage and be able to get better preventive services earlier in the trajectory of their care. So this led, and we've been widely successful in that portion of the project that I just described, to a proposal that went to PCORI for a trial called Wisdom, which would take this model one step further. So there's, as you well may know, a huge screening debate in the US, when to start, when to stop, what the screening intervals should be. There's not a tremendous amount of guidance as to how to operationalize risk assessment. Some individuals are underscreened, overscreened. Preventive services don't reach all of the women who might most need them. And women are generally confused and frustrated because depending on who they go to, whether it be a radiologist or whether they go to their primary care provider, may get conflicting sort of recommendations in terms of what the best way is for them to manage their risk. And women are often caught in the middle. Here you can see a bunch of sort of headlines from the press in terms of what the value is of screening and what the value isn't of screening mammograms. And the dangerous part is that there are a lot of women who may benefit from screening who are not screening at all, because when there's controversy, sometimes what gets lost is whether there's any value to any population at all. However, reformulated or revamped breast cancer screening could be based on advances in risk assessment, the underlying biology of the individual, trying to find relevant cancers versus cancers that are not going to have an impact on the patient. It can be integrated with prevention. It can be more cost effective, and it can be personalized. And so the approach to that is based on this sort of continuous improvement trajectory, that what we really want to do is we want to look at screening and develop new approaches, integrate additional information into the screening process to better target women, define what the screening intervals should be, and then define of the people who may end up having findings on screening, who should get prevention, who should get biopsy. So the trial design that is about to start in a pilot fashion at UCSF and then extend to all of the UC campuses is basically to take this pool of eligible patients who come in for screening mammogram and consent. And if they consent to be in the randomized cohort, they get randomized to either annual screening or whatever the baseline amount of screening that they, whatever their standard screening regimen is, versus risk-based screening, which takes into account a variety of data that I'll talk about in a second, versus an observational cohort that basically would get the same sort of groupings, except that they wouldn't be randomized to it. They could self-select which group they want to be in, whether they follow the risk-based recommendation or not. And the risk-based screening arm is basically designed so that in addition to what we have been doing, which is collecting a bunch of information on a questionnaire, family history, comorbidities, a number of previous biopsies, age, race, and ethnicity, that we would include data that comes from their breast density from the previous mammogram that they had, include genomic profiling that includes both a set of 9 genes that I'll describe in more detail, plus 81 SNPs, and put that all in a revised risk model that would not only determine whether or not they're at risk and may benefit from prevention, but also determine what their screening interval should be for subsequent breast screening. And so there may be people who might need additional types of modalities of radiological interventions, mammogram plus MRI. There may be people that need more frequent screening or less frequent screening or no screening. And the population of people that, for example, I'm most interested in are older individuals that have multiple competing diseases and may have a very low risk in terms of developing cancer. And at what age is it appropriate to stop screening those people? The current recommendations are very age-based, even though I tell all my fellows and trainees that it's not their chronological age, but their physiological age. But really the truth is it's their physiological age plus a whole variety of factors that determine whether they're at high risk or not for developing breast cancer. And is there better ways of modeling that to then determine what their screening notification and what education goes not only to the patient, but to the primary care provider as well. So just a quick note on breast density, because it's one of the newer components that's going into this Wisdom trial as an element of data. It's really the amount of fibroglandular tissue that's on a mammogram. Historically, the mammogram reports kind of report this qualitatively, whether it's 1, 2, 3, or 4. It's almost entirely fat, or it's extremely dense. It's not particularly precise. Although epidemiological sort of studies have shown that breast density is independently a risk factor for breast cancer, no one would necessarily say that the way that we're currently reporting it is optimal. More importantly, there's a lot of legislation around reporting breast density. So now you have to report it to patients in the state of California, but patients don't know what to make out of it. They are told that they're, have dense breasts, but what should they do about that? And radiologists aren't really sure what they should do about it either, other than the fact that the state requires them to report it. Because the truth of it is, it's not just the radiological finding that defines what you should do about it, but a variety of the other data that I just described that might identify whether the patient's at high risk or low risk for developing breast cancer that have to be integrated in a way to be able to determine what the next step should be. So both breast cancer and breast tissue are both white on a radiological image. Fat's nearly black. So the greater amount of fat, the easier it is to recognize someone with cancer, which is why even though we tend to suggest that older women should be screened less, the truth of it is that because they have fattier breasts, the likelihood that the screening will find something in an older woman is much better in a younger woman that has much denser breasts. And the breasts, could be heterogeneously dense. And as I'll show you, here is a cancer in a fatty breast. I don't have a pointer, but you can see on the left side that there's that big white mark that's different than the tissue that's around it. It's much easier to notice that, regardless of which way you're looking at the breasts in terms of the images. It's just clear, whereas, if you had a dense breast, you would be much harder to know what's exactly going on here because there's so much white background noise that you could easily miss a tumor while it's there. Now, this is from a diagnostic standpoint, but as I mentioned, epidemiologically, independent of the diagnostic challenges, people with high breast density seem to have a higher risk for developing breast cancer anyway. And so, the sensitivity and specificity is reduced significantly. Additional false positives, as I mentioned, there's an independent risk factor for breast cancer, about 4 to 5 times the relative risk. And there's a California law that mandates that we have to tell patients about this, but not necessarily that we have to tell them what to do about it. So this is a classic sort of opportunity to try to figure out how precision medicine or interventions in this way can actually do something useful when there's already legal requirements of communicating something to a patient population. In addition to that, there's the genomic component of it. So, the genetic architecture of breast cancer, where you have these known familial cancer risk syndromes with BRCA1 and 2 that convey a tremendously higher relative risk of developing breast cancer, but they don't affect a large proportion of the population. And then you have things that are genomic variants with intermediate penetrance that may have slightly more frequency, but much more lower relative risk. And then ultimately a lot of single nucleotide variations that have been determined in these genome-wide association studies in populations to have very small individual relative risks. But we don't know in aggregate whether or not they're very predictive of someone who may be at risk for developing breast cancer but may not have a hereditary syndrome. And so this is the playing ground for the types of things that one can look at to try to determine whether there's some genetic risk for breast cancer. And there's about 7 years of data from these genome-wide association studies. You can see that these odd ratios, range anywhere from like 0.8 to 1.3. They're relatively low. This slide suggests that they're 76, but every sort of month or two, 1 or 2 get added, and I think we're up to 81 now. And so there, the people that are researchers in this area have models where they can integrate the risk, even though it's low, across all these genes into a model that can then determine whether or not someone who may not have a strong history of breast cancer still has a higher or lower risk of developing breast cancer. For the particular purposes of the study that I mentioned, 9 key genes are going to be done on the entire population of patient coming in for screening. So every patient that comes through the door will get these 9 key genes tested, as well as 81 SNPs. And the 81 SNPs look at not only known and accepted risk variants that I just mentioned that come from these large studies, but also discovery variants that might affect specific breast cancer pathways or cancer signaling pathways, and other disease and treatment modifying variants that may play a role if someone's diagnosed with breast cancer in terms of what their pharmacogenetic response might be. And the idea is to take this large population of screening patients and take all this data that comes in and ultimately use it with outcomes that can only come when you have a large population of patients where you follow them over 5 years or 10 years to come up with better tailored screening recommendations for the individual woman. And so we would be taking all of this data the way that it's designed, and then the follow-up will be screening frequency and whether cancer is detected, and then the risk-based approach in terms of the screening interval would then be tailored based on not only what their screening interval is in terms of age, which is the traditional way this is broken up, but to take the additional information and then break them up into the highest risk, elevated risk, average risk, and lowest risk. And then, potentially people that aren't screened at all if they're over the age of 65 and have a high comorbidity and their molecular profiling determines that they're at low risk. So this is kind of the approach for this PCORI pragmatic trial that's about to begin across the UC system. How does this compare? So, the idea is that if we are able to demonstrate that risk-based screening is as safe or safer than in terms of identifying clinically detected cancer with less false positive recalls, then this approach to doing risk-based screening rather than screening guidelines that suggest that you kind of determine what the screening is by age is an innovative way forward. And there have been some modeling done around this where you can see that annual screening costs a lot of money, and the actual practice is leaning to doing less annual screening. And actually, if you did screening every other year, you would save a lot of money. But you can get close to biannual screening by doing risk-based screening, where you don't make a rule necessarily whether or not everyone gets screened every other year or every year. A small population of high-risk women can get screened more frequently, whereas the vast population can still get screened every other year. And that may be just as cost-effective, but may yield to better clinical outcomes. So what are the transformative and innovative possibilities when you're trying to integrate these sorts of complex data in a project like this? And I'm just going to highlight 3 or 4 of them that I think are interesting to stimulate the discussion, because I don't have that many slides left, and I want to lead to a good discussion. So one is, what's the current paradigm to dealing with the high-risk patient and genetic testing? The current paradigm is we first identify whether you're high risk or not. And if you're high risk, you go to a genetic counselor. They sit down and they spend an hour with you. Then they call up 3 of your family members that might have the disease. They try to figure out who, if we're going to do a genetic test, should provide the blood for that. And then you go get the genetic testing done. That's the current pathway. But a possible future paradigm might be that we take all of the information that I described and we do a very low cost first pass molecular genetic screening on the entire population. More and more of these tests are costing $150 to $200 per patient, and the costs are just going to go down. And then, based on the data that comes in, we determine who needs to get genetic counseling. And then the genetic counselor has the advantage of having some screening genomic data to kind of help them along. And it may be then that based on that, we do more in-depth sort of genomic testing, whether it's whole exome or whole gene testing. It would just change the paradigm in terms of when the genetic counselor gets involved and who determines whether they're high risk or not. And is there a way that we could do population-based screening where you do it just once, but the entire population of patients get it, and the genetic counselor comes in as a secondary phase in that process. Same thing with screening and imaging. I mean, currently everyone goes for a screening mammogram, and then depending on if they see something or not, or what the clinical suspicion is, they may get an ultrasound, an MRI, some other imaging procedure, and that may ultimately lead to a biopsy. But the future might be that what we're really looking for are circulating tumor cells. And if we could identify as circulating tumor cells and really had a high suspicion that the person actually has cancer, then it would flip the whole process of imaging upside down. The imaging wouldn't be for screening. It would be to find the cancer that we already have a very high suspicion that the patient has. And the modalities that would be used in that circumstance would be completely different because we're looking for something that we really think exists versus doing massive screening. And then it may lead to either biopsy or directly to surgery. And this may be the future, really, of how we approach screening in this population. Also, in terms of how we utilize invasive procedures overall. Right now, anyone that has an abnormal mammogram of 4A, 4B, or 4C is likely to get a biopsy. A lot of the people that have 4As have a very low positive predictive value of having cancer. It may be on the order of 15 to 20%. So the outcomes will be heterogeneous as a result. But it might be that taking an abnormal mammogram and adding a variety of clinical and pathological data, including genomic data, can better target patients that may be amenable to watchful waiting versus a biopsy, and then can lead to the same outcomes at the end without subjecting a lot of people to invasive procedures at high cost with some morbidity, because any invasive procedure you have, there's some risk to performing. And then lastly, I think there's more and more sort of emphasis on trying to develop smart imaging, whether this is trying to go from qualitative breast density to quantitative breast density and develop algorithms that take MRI information and mammogram information and take that categorical list that I have and add a numerical number to it that might have a lot more precision and predictive value, as well as automated image interpretation and computer-assisted diagnostic, which is an evolving field, not just in breast, but in lung, and a variety of other fields to try to figure out how much value we can get out of an image, more than, for example, what the individual radiologist might read off of it in terms of interpretation. So I think setting an infrastructure or foundation in terms of collecting a diverse set of data that includes patient data, clinical data, pathological data, genomics data, imaging data on a large population of patients really allows for doing some exciting and innovative things, and really can help take big data and then actually transform it in a way that has impact in terms of clinical care and knowledge. So I'd like to thank a large group of people, because even though I'm giving a talk today, clearly you can see that this is a group effort across multiple institutions, but I think it gives a clinical example of what you all have been trying to really do, which is try to figure out how to architect taking all of this data and actually transforming it to knowledge. And so I'm really appreciative of the opportunity to kind of present a use case for that. Thank you.
So, Arash, this is very impressive. You probably know what's going on much better than we do, but we also been alerted that one of the critical issues of dealing with clinical data, number one is patient privacy. Number two is how do you work with the IRB issues when you build networks. And I was wondering if you could comment on these elements.
Yeah, I think that there's two or three sort of aspects to that. One is that I think so clearly there's what we know today. And so if we're doing something based on what we know today to improve the quality of the care that we're giving to patients, that's not research, that's quality improvement. And there's what we don't know today. And in a lot of these projects, that's ever evolving. What we don't know today will become known tomorrow and then be part of the clinical care. So the characteristics, I think, of most of these sort of precision medicine type of projects is really emerging between the research and the clinical arm. You start with a basically rough model of what's known, that's quality improvement, and you're continually analyzing the data, validating it to add and then improve the model and improve the precision of it. And so, of course, in trying to negotiate with security officers and compliance, how you manage a project that's both quality improvement and care and research is challenging, and it requires really due diligence in terms of setting the rules of engagement, in terms of who has access to the data for quality and who has access to the data for, for analytic exercises to define where the new knowledge is and to validate it. And I think a lot of time is spent on identifying where the privacy issues are, but a lot of the knowledge part doesn't necessarily require knowing who the patient is. This becomes a little bit more challenging if you're doing whole genome studies or exome studies where technically it's a fingerprint quality of it that by definition, even if you strip all the other identifiers become kind of challenging to manage. But I think we have a responsibility as the academic institutions to convey to our patient population that behind the scenes, we're trying to improve their care through this type of research and to try to get most of our population up front to agree that they're interested and willing to be participants in this process in terms of some sort of community partnership. And patients can volunteer their own information for these projects. In fact, there are a lot of websites where you can upload your own genomic information that doesn't have the same sort of privacy and compliance issues because the individual's electing to share their information in an open source or public way. And the reason that works is that they've bought into the idea that there's more value to them in sharing their information than the risk there is to their privacy. And I don't think we do a very effective job in terms of academic institutions in conveying the risk proposition to our patient populations when they come through our door as to why it's so important for them to partner with us. There is risk. We'll do our best to manage that risk, but that risk is no more than going to a bank teller or any other thing that we're so accustomed to these days anyway. And they just need to see what the upshot is in that sort of risk proposition.
You talked about having to only get data once from individuals or from sources or from, preventing having to keep going back and asking the same person for the same data. Talk about how you prevent that.
Yeah, so of course, there's two pieces to that. In the context of this project, for example, whether they're of Ashkenazi background is not going to change. Or when they had their first menstrual cycle is not going to change. So there are elements of the data that we could keep asking them, but are never going to change. And then there's aspects of the data, like their family history, that might change, but from a year-to-year basis, the likelihood that a large portion of that information is going to change is low. So for this particular project, the ability for the patients to put in the data once, and then when they come back in the next time, for them to be presented with the data where they only spend time with updating it is important in terms of, again, we're trying to partner with the patient population that it's worth their time to provide us with more extensive data to do our job, which is to do a better job modeling their risk. And we have to do a better job there. Now, part of the problem is, though, is the data that I'm collecting for this shared when they go see the oncologist or when they go see the surgeon, or do they have to do that all over again? And I think in the next 3 to 5 years, we need to figure out better ways of interchanging data so that even that part is shared in a much more efficient sort of a way, because it's very frustrating even when I'm a patient myself to have to continually fill out the same form 10 times over when I'm going to see a provider. And if I even get a whiff that part of the data that I'm providing has just research purposes, then I might get angry. And I might not understand that it might have dual purposes. It might have benefits in terms of clinical care as well as research in terms of improving my clinical care the next time I come back. And so I think the more efficient that we can become in terms of making sure that the data is available, the easier it is to engage patient populations to provide us with more data that might help us better target and personalize their care.
So one aspect you brought up is your vision and leadership to see how patient care process will shift from one existing model to another, where I see all these words that kept repeating in your slides is patient engagement and patient participation in this whole process. Do you see there are specific areas where either web-based services, interfaces, or other tools should be created to facilitate the engagement of patients and in their own data, I wouldn't say management, but partnership in this whole healthcare transformation process?
Yeah, I mean, I think one of the elements that probably doesn't get as much emphasis as it should be is how do we convey more complicated information to the patient population? So, we're very, very interested in taking complex data and building better models and saying that we're providing individualized, personalized, precise, but that means that we have a lot of data. It's hard enough conveying unsophisticated data to patient populations. How do we convey sophisticated information to patient populations? And I know that that's a challenge because I can't even convey sophisticated information to primary care providers who feel a tremendous amount of stress and anxiety of having that information communicated to them because of the fear that if they're not appropriately responsive to the information that's being provided, there's medical legal sort of liability that they should have understood it and done something, but then they didn't do it, and then something bad is going to happen to the patient. So I think we're moving faster in our ability to do things with the data than we are in figuring out how to convey the results of what we're doing to either patients or to providers. And there's a lot of work that can be done there, but I think patients are willing to be partners in that process, but we have to think about how to make the data more usable to them, synthesized for them, and it can't be that they just get data without knowing what to do with it or what the next step is. Like, for example, even though we communicated to them whether they're high risk or not, I mean, that's the basic communication they get in this initial phase of the project that we did, we sent them a letter, but they may have opened the letter at 8 p.m. at night. So if you open a letter at 8 p.m. at night that says you may be at high risk, we're not sure, maybe the data that you gave us was wrong, you can call this number, but there's someone there only from 8 a.m. to 5 p.m., well, you may be very anxious until the next morning. So providing them a link where they can go online that tells them what it means to be high risk so that they understand and have context to the information, as well as maybe a link as to how to manage your anxiety until the next day. Those are the sort of creative ideas that we have to figure out if we're really going to do a good job communicating with this patient population as we have more information that's more complicated that we want to be able to share with them or other people. And I think that's a huge area. The other thing is, of course, that when you do projects like this, it's not static. It's very dynamic. It's data over time. It's imaging over time. It's genomics over time. And the times may be, relatively close to each other, but they may not be the exact same date. And so trying to define what episodes are, appropriate analytic episodes of care are, how do you link these disparate data that might not happen temporally exactly at the same time, a lot of valuable effort there. But also, a lot of these patients that might be at high risk, their genetic SNPs, there may not be anything interesting there, but they may develop cancer 10 years from now. And their blood test from 3 years from now may have the interesting piece of data. So if I can't figure out a way of serially getting samples or blood or data to kind of suggest why is it that this population didn't have anything interesting today, but they developed cancer 10 years from now, did something change along the way? And so trying to figure out how to communicate ways and come up with innovative ways where we can use leftover blood, residual tissue, where they go in for a regular blood test, but they are willing to give an extra one, that doesn't take any much longer time, doesn't take any more pain because the needle's already, been stuck in. How do we really integrate our efforts to collect data in a way that is unobtrusive and not a painful process is going to be a critical element in terms of being able to collect the data that we need to be able to do this effectively.
I do want to follow up with a comment that to what you just said, because oftentimes when we're thinking about big data, I will hear people who aren't necessarily involved in big data say something to the effect of, well, why do you want to collect, integrate, and store that data? Why don't we just redo the experiment when we need it? Mm-hmm. And I think that you're making a point that really does need to be emphasized a little bit, which is you don't really know tomorrow if the data you had today is actually valuable or not. So being able to quickly derive knowledge from that data, search and index it, is really important for those types of questions. So thank you. I think that if that could be emphasized.
Well, and I think it also changes the model of these very expensive biospecimen repositories, because if you're going to have to keep all of this specimens so that you can continue to rerun something, you're going to have to bank it. So you can imagine banking, screening population samples is you need a large bank. It's could be even prohibitively expensive to do that. Whereas if you get the tissue and you do a whole genome on it, and you preserve the data, but you don't need to hold the tissue, and whenever you come back with another hypothesis, you have the full set of data, well, then you've taken away the costs of biospecimen repository, and you've invested in the data. And so I think trying to think of interesting models where we invest more in the data and less in archiving samples may help us in better sort of figuring out how to do things on a larger scale, which might be difficult to do without some efficiency.
Yeah, especially when we're moving forward with 1 million patients.
Yeah, exactly.
It's just impossible to store all those stuff.
Yeah.
Okay. So I have a question about the technical and logistical aspects of the data interchange. So I assume by being part of this network, what that means is that patients seen at each site, in the process of bringing them all together, each site is writing sort of a data extractor out of their EHR that assembles all the relevant data into a common format. And I wonder if you could just talk about the lessons learned from that process, in the sense that if you had to think about initiating a new network, on colon cancer tomorrow, right? How much of that greasing the wheels has already been solved, or if you wanted to integrate a new site. Can you just talk about some of those details?
Yeah, so I think, so there are several elements to that question. One is that even though we standardized, let's say, for example, the patient-reported data across all the 5 UC sites, which is no easy task in and of itself to agree, the date that each site went live and each site updated their system as changes occurred were slightly different. And so version control in terms of how systems change over time adds a layer of complexity that we've been spending a lot of time managing. Even though we all agree on what the standard is and we have governance around controlling it, the changes don't hit all the sites simultaneously because each of our control points have different change control things that delay changes from hitting each of the sites, and that creates problems in terms of when the changes hit. I think that aside, there are certain things like, for example, trying to figure out how to make sense of developing a comorbidity index out of electronic healthcare record, which is a very messy, sort of unclean effort to do, probably does not have tremendous amounts of difference across all the sites. So a validated approach that the sites agree on can probably be moved across the sites fairly well, but that doesn't mean without any additional effort or programming at each of the sites, because although we may have a similar approach, there's nuanced differences, and the portability of that, for like Epic, which is what 4 out of the 5 UC sites use, is not so great that you can just write code here and then be able to use it at another site. I think where it becomes really challenging is that the folks that are focused on data are looking at the data, but they don't really have a clear idea of what the context was when the data was entered. And this is where I think the biggest risk is that the folks on the data analytics side are trying to analyze data and clean it up. But the context of when the question is answered, when the data was collected, how invested was the person in terms of the accuracy of the data point, that isn't just a question of whether it's similar or different between divisions or departments. It's whether it's similar or different between subspecialties, providers, how busy they were. And that adds a lot of noise to what I think the quality of what could be the data. And so I think that requires more sophisticated methodologies in terms of the people that work with data to take into account a larger degree of uncertainty in terms of how much they can, weigh an aspect of the data if it's unclear that the context of collection of the data is standardized. And so people oftentimes don't understand how the data is collected. Like when I sit down and look at oncology data with the people that have pulled the data out for me, they have no clue how I entered the data. Well, if you have no clue how I entered the data, how can you say anything about the data on the back end? You have no idea of what I was doing and the context of how that data was entered to begin with. And I think that's going to be a huge bridge, because I think there's a lot of noise in terms of that aspect of the data.
So for a non-clinician, can you give an example of where, the context matters in terms of how you interpret the data?
Right. So for example, diagnosis, right? I think diagnosis, people are trying to figure out, does the person have the diagnosis? Do they not have the diagnosis? So for example, in our system, I can enter something in the problem list. I can enter it under the visit diagnosis. If I enter it in the problem list, I can put a start date, or I could put an end date. But on the visit diagnosis, I can't. It's for that visit. Are both aspects of the diagnosis that's put in the problem list and the visit diagnosis equally reliable? Is one more reliable? What if it has a start date but never showed up as a visit diagnosis for the last 10 visits? Is it active? Is it not active? There's no end date. How do you reconcile what the real diagnoses are when you're trying to risk stratify a population if you don't know how the user in their daily encounter, how they're using the system? Are they the type of person that puts it in the problem list? Are they the type of person that puts an end date if it deserves to have an end date? Are they using the system even correctly? Those I think are the issues. And we stratify populations based on these sort of ICD-9 codes all the time, but without really knowing whether or not the way that the user is using them makes the data point that we're using for the risk stratification reliable or unreliable.